Good evening, ladies and gentlemen. Welcome to this ESAIC webinar, the new resuscitation guidelines. Today, we have the pleasure of 4 experts to discuss the two new chapters of the 2021 resuscitation guidelines created by European Resuscitation Council. Now, the community resuscitation programs may not seem important to hospital practitioners. However, fragmented patient care ultimately yields poor outcomes. These 2 chapters emphasize the importance of cardiac arrest epidemiology and systems for saving lives. My name is Dr. Arash Afshari. I'm from Copenhagen, Denmark, and I'll be your host tonight. Let me introduce our speakers. That will be Professor Bernd Böttger from Cologne, Germany, Professor Sharon Eine from Jerusalem, Israel, and Professor Ayten Sarıcoglu from Istanbul, Turkey. And she will be our scientific support. Now, as you will see the next slide, this is the name of the presenter, and we will also have a slide with our conflict of interest there. I'd like to emphasize the fact that this webinar is not sponsored by the industry and is exclusive for our ESAIC members. And for you, our audience today, this is an interactive webinar, so you can send your questions to us, and you can do so by clicking this blue button up there in the screen, as you see. It's a submit button, and you can do that at any time during the live webinar. Ayten is going to pass us the most important questions so that we can share our professional opinions with you during this webinar. It's also important to emphasize that this activity is accredited for 1 CME point. And in order to get your points, please do not forget to complete the assessment and the evaluation at the end of the introduction. I'm going to start with the first speaker, Professor Bernd Böttger from Cologne. He is a distinguished member of our society and has been basically a core member of all of these recent guidelines on resuscitation. Bernd, please.
Yeah, thank you very much, Arash, for this nice introduction, and welcome everyone. The key messages of the ERC Resuscitation Guidelines 2021 in 15 minutes. It's a challenge, and we will make it. So welcome, everyone. You can see here the process. We started in 2015. It's a very highly sophisticated process. We have analyzed all evidence that is available under the umbrella of the International Liaison Committee on Resuscitation. And we wanted to publish the new guidelines in 2020. But then COVID came, and we first published the COVID guidelines. So the new guidelines have then been published on March 2021. Following the ILCOR consensus with science and treatment recommendations statement, which was published in October 2020. These are the logos, and as already pointed out, these are the chapters of the new guidelines, and you will probably recognize that most of the chapters are similar to the guidelines that we have seen before, besides the fact that we have 2 new chapters in the guidelines, which are most important, which is epidemiology and system saving lives. And it is very good that in all the other chapters, not so much has been changed, although we have done a big job and a great job and written all this down, supported by the newest evidence. And since these are the 2 most important chapters in my eyes, I will primarily focus on them at the beginning of my talk. And before we start, it's going back to Arash for the poll.
So let's start the presentation by this poll. And I think it's very important for the audience just to know that what's important is we'd like to have your opinion on it, and we'd like to know which answer is not correct. So question basically is, I will give you the option A, B, C, D, E, and you just have to answer the one that you do not believe is correct. So A, out of hospital cardiac arrest is the 3rd leading cause of death in the industrialized nations. B, following cardiac arrest, the brain starts to die after 3 to 5 minutes. C, late resuscitation before arrival of the emergency medical service system is associated with an up to 3-fold increase in survival. D, amiodarone is just as effective as lidocaine for treating persistent ventricular fibrillation following cardiac arrest. And finally, adrenaline is not recommended anymore during CPR. Please cast in your vote and click the blue Send My Vote button. The poll will close in 5 minutes. Ayten will then share the results towards the end of the presentation by Bernd.
Thank you very much, Arash. We start with epidemiology. So We have a lot of nice pictures in our guidelines that can be used for presentations and for graphs and photographs. So please use them. And this is one of them. And as you can see here, with regard to the rate of lay resuscitation all over Europe, this is between 13 and 83%. So the rate when lay people start resuscitation before the arrival of the emergency medical service system, which is most important. And survival rates all over Europe are between 0 and 16%. And for example, in my country, we are in the middle. We have 40% lay resuscitation rate. In Scandinavian countries, they have 80%. And we have an average survival rate of about 10 or 11% in Germany. And you may know your numbers from your countries as well. This is out of hospital cardiac arrest. In hospital cardiac arrest is another issue and another problem. And if we taken all this together, we have 350,000 out of hospital cardiac arrests and 250,000 in hospital cardiac arrests. And this is about 1,650 deaths per day. This is as if 3 jumbo jets are crashing down every day all over the year in Europe without any survivors. This is the amount of the healthcare problem we have. And how can we come over this big healthcare problem? The most important chapter in the new guidelines for this is system saving lives. Why is that so? Because we have the 5 key elements to improve overall survival following out of hospital cardiac arrest. And I will briefly point to all of them individually. The first part of the System Saving Lives chapter is raise awareness about CPR and defibrillation. This is because the chain of survival, you all know the chain of survival has been changed over the last years. And the first the first rings are much more important than the others. This is the in-hospital setting. It's not so much important what you're doing there, but it's very important that you recognize cardiac arrest and that you start CPR before the emergency medical service system is arriving. And therefore, political action is needed. And that is the reason why in Europe and since 3 years now all over the world, we have established the European and then the World Restart a Heart Day. You probably already know something about that, because we have 3 times more survivors when lay resuscitation starts before the EMS is arriving. And that's the reason why we're doing all these campaigns. World Restart a Heart Day in 2019, we have reached more than 200 million people and we have trained more than 5.4 million people under the umbrella of the International Liaison Committee on Resuscitation. In the year of the pandemic, we did a virtual thing called My Song Can Save Lives, where David Garrett, Culture Candela, and Andrew Lloyd Webber and the Vienna Philharmonists told their listeners and their followers on social media that their song can save lives because they had the correct rhythm in their songs. And that is the way we proceed. And this is the publication, more than 200 million people reached. You can see it here. And all this is also supported by the International Federation of the Red Cross. They went out into 194 countries of the world to support our initiative. And these are all the participants of the World Restart a Heart Day all over the world. And the ESA and then the ESAIC is one organization that is taking part in this. So please join us on October. It's always on October 16, which is also the World Anesthesia Day. And you will find much more information on our websites of the ILCOR and the European Resuscitation Council. Second thing is System Saving Lives is use technology to engage communities. What is meant? It is meant that you should have first responders, professional or lay people that are dispatched in parallel with the regular EMS system. And usually they reach the victim in more than 40% before the EMS is arriving, so they can bridge the time if lay resuscitation is not established. So first responder is another very important thing, but it is not very much implemented all over Europe. So please help to implement this. Next thing is educating school children in cardiopulmonary resuscitation. This is the Kids Save Lives initiative. You will find much more on our websites, and this is the logo. And We also have the logo for pandemic times. As you can see here, this is the start of our campaign in Germany. So it is supported by the World Health Organization. And this is the Kids Save Lives maps of Europe. It is mandatory by law to educate school children in resuscitation in 6 European countries, but it's only a recommendation in 24 additional European countries. So please help us to establish school children education in Europe and in the world. This will save hundreds of thousands of lives every year. Our suggestions start with check, call, compress, check for signs of life, call the emergency and do cardiac compressions. In class 7, age years 10 to 12, you can even start in the kindergarten with check and call and add ventilation and AED at the age of 14 or 16. We can do a lot to improve here. Next is cardiac arrest centers. We know that people after out-of-hospital cardiac arrest should not go to any hospital, but they should go to a hospital where immediate coronary intervention is available on a high level, 7 days a week and 24 hours a day. Cardiac arrest centers will probably improve survival by 2 times if people reach the cardiac arrest centers early. And this is the implementation map in Germany. We have established criteria and we have established audits for cardiac arrest centers in Germany and also in Switzerland and in Austria. And so we have just a good implementation already in the German-speaking countries, but in Europe it is just starting. So please help us to establish cardiac arrest centers also all over Europe. Last not least, telephone CPR. So if the caller is calling the dispatch center and then the dispatch center is explaining the caller how to do cardiac compressions, that is also very effective with a number needed to treat of 7. But implementation is bad to mix. So please organize in your area, in your country, in your city. Please organize that telephone CPR is administered to all cardiac arrests. And what do these animals do in a presentation about the new guidelines? You probably know that these are called the Big Five, and we had a publication and that one picture is telling us more than many words. So please always think about the Big Five strategies for survival following out of hospital cardiac arrest. This is not a drug or this is not a defibrillation, but this is, you can see here the Big Five here, and you can see here the estimated impact on survival. Increasing lay resuscitation rate, 3-fold increase in survival, telephone CPR, 2-fold increase, first responder systems, up to 2-fold increase, experienced ALS teams, 2-fold increase, and cardiac arrest centers, 2-fold increase in survival. So these are the things that we should do. And these Big Five correspond very well to what we have seen from the chapter on system saving lives. So now we have a few minutes left for all the other things, and I will briefly come to the infographics about basic life support. And as you can see here, we say recognize, alert EMS, and start chest compression. So nothing has been changed with BLS since the last guidelines 5 or 6 years ago. And the international message is check, call, and compress. That is the message to all lay people. And this is the algorithm that has not been changed. So I can go through this a little bit more fast. With regard to advanced life support, I would like to draw your attention to the most important message. Message number 1, compress without any pauses. Use the defibrillator and look for any different causes of cardiac arrest. Next is cardiac arrest prevention and the implementation of medical emergency teams in hospitals for in-hospital cardiac arrest. Next is oxygenation. So you do not need to intubate the trachea. You should use the technique that you are best with. So you should oxygenate. You can also use supralaryngeal masks and other masks for oxygenation. With regard to drugs, adrenaline is recommended. New studies suggest that lidocaine is as effective as amiodarone, so you can use both. And thrombolysis should be given during CPR for pulmonary embolization. Don't forget this. And if you cannot stabilize a patient with conventional measures, please think about eCPR or ECMO. Extracorporeal support can be implemented in hospitals and in some areas also out of the hospital setting. We have studies suggesting that in individual cases, this will help patients to survive. The algorithm has not changed very much, so I can again briefly and very fast go through it. So please think about intravenous access. Intraosseous access is not as effective, but if intravenous access cannot be achieved, use an intraosseous access. And please always think about different causes of cardiac arrest, even during CPR. And I would like to draw your attention. Please have a look into the chapter Special Circumstances. A lot is said about drowning, pulmonary embolism, acute myocardial infarction, and all these different things, but we do not have the time now to go all through this in details. With regard to post-resuscitation care, we will hear a lot from Sharon on this in her case. The key message is oxygen saturation should be between 94 and 98 and not higher and also not lower. This has not been changed. Please remember that in 60 to 70% of all out-of-hospital cardiac arrests, a coronary event is the underlying cause of deterioration. So many patients should go immediately, at best in the cardiac arrest center, in a PCI lab. And please, these are the recommendations for temperature management. 32 through 36 for at least 24 hours, no fever for 72 hours. That has not been changed over the last years. Prognostication not earlier than 72 hours, because otherwise you will make some mistakes that are probably not in the interest of the patient. And please think also about rehabilitation. There is a lot about rehabilitation also in the new guidelines, and this is also a little bit a new chapter. And we have a lot of infographics that you can put in the rooms of your ICU with all the key messages in our guidelines, if you like. And this is about prognostication. I repeat, do not do it before 72 hours, 3 days after cardiac arrest, because otherwise you can make a lot of mistakes. Use at least 2 of these, which are printed here. NSE is only 1. Papillary and coronary reflexes is another. And you can see here all the different investigations that can be used for prognostication. At least 2 of them should be used. And then finally, last not least, hypothermia versus normothermia after cardiac arrest. A New England Journal publication has been published after the publication of our guidelines, suggesting that normothermia is as effective as hypothermia following cardiac arrest, but we need to look very carefully into this publication because, as you can see here, they have a high rate of bystander witnessed arrest, 90%, bystander CPR performed in 80%, shockable rhythm 75%. This is at least not my patients in Germany and maybe also not your patients in your country. This is the temperature curve, and you can see here the temperature is down after 6 or 7 hours, but as you can see here, this is not hours after cardiac arrest, but hours since randomization. So they reached the target temperature several hours after the arrest, and maybe this came a little bit too late, and maybe this is also the reason why they have not found any difference between the 2 groups in this particular study, also no differences in the subgroups. Downtime before start of CPR, maybe only 1 minute, which is not very much. Lay CPR and shockable rhythm very high. Therapeutic window, these are probably not our patients. So target temperature reached after more than 7 hours after cardiac arrest. Please take this into consideration. We are still cooling our patients after cardiac arrest despite this study. There are many further chapters in the ERC guidelines. I cannot go into any details because of the time. And finally, I would like to summarize. Please always think about the big 5 in resuscitation. This is the message of the new guidelines. Everyone can and must save lives. And please think about educating school children, participating at the World Restart a Heart Day, use telephone CPR in your community. use first responder systems in your community, do good CPR and advanced life support, do bring your patient to a cardiac arrest center and do good post-CPR ICU treatment and prognostication. And for all this, the support from politicians is needed. And we are approaching politicians all over Europe to help us to improve all over survival. Don't forget the big five. And please join us at World Restart a Heart on October 16 this year. We have the motto, CPR can save my life. Many further informations on our website. We will be able to save, if all anesthesiologists and others work together, we will be able to save 100,000 lives every year in Europe. And not only in Europe, this is from Brasilia, where school children education is now mandatory by law. And please start the brief video as a final slide.
It only takes 2 hands to save a life.
That is my message. It only takes 2 hands to save a life. So everyone can do it, not only doctors or nurses or paramedics. Thank you very much for your attention.
Thank you very much, Bernd, for an excellent presentation and indeed very concise. And the message was very clear. Indeed, everyone can and must save life. Ayten, could you please take us through the results of the poll?
Yes, Arash, and we have our results from the participants, and 77 correct answers we have. Adrenaline is not recommended anymore during CPR. And dear Bernd, what do you think about the results?
Thank you very much. I'm very happy with this result because most of the people are really have done the right answer. And the amiodarone question number D, it's interesting because it was amiodarone was recommended at a higher level than lidocaine in the previous guidelines. And this is one of the changes we did in the 2021 guidelines. So please remember, lidocaine is as effective as amiodarone. And I think all the other numbers are very low. And I was also surprised when I saw this for the first time, this number A, that out-of-hospital cardiac arrest is really the 3rd leading cause of death in industrialized countries. And that is a place where anesthesiologists in Europe and all over the world can really do a great job in educating lay people. And this will even attract more people about our specialty and make our specialty much more visible in public. And that's the way we are going in Germany and in many other countries of the world. Thank you very much.
Thank you very much.
Thank you so much. Thank you, Bernd, for this very interesting presentation. And that leads us to the next topic on the case scenario. And before we do that, I'd like to remind you and our members that you can continue sending questions by submitting that through the Ask the Speakers blue button. And Ayten is going to continue to pass us the questions, and we can share it with our professional opinions at the end. And we will have time for discussion, hopefully. It's my great pleasure to present my dear friend Sharon Einer from Jerusalem, and I'm sure she will take us through some of the other aspects of this topic.
Thank you. So I'm going to talk about the conference report and expert panel. I'd like to thank Dr. Ramlawi, who helped me prepare this. And without further ado, I'm going to start with the case that a 66-year-old woman after cardiac arrest is on the way to your hospital. I will be asking several questions which refer to this specific section of the post-resuscitation care. And if you go into the guidelines, everything is pretty much spelled out, so I'm going to run through this pretty quickly. So the patient has no cardiac history. She had a mild chest pain before the arrest and dyspnea for 2 weeks. This is the electrocardiograph at the time of arrival, and as you can see, there seem to be some ST segment depressions, and particularly in the lateral wall. And my first question is, what do we do? Do we rush to the coronary catheterization lab? Do we need to do anything else? So in the guidelines, the important part is to know what to look for. Like Dr. Bodiger said before, there needs to be a clinical or ECG evidence of myocardial infarction, and indeed, there are quite a few patients who may require coronary angiography. If there is no ECG evidence, then there might be need to discuss the case individually. Respiratory symptoms will take us to another direction, which would be CT angio, and neurological symptoms might also be accompanied by ST elevation. So having said this, this is the paper that was performed showing whether coronary angiography needs to be done immediately or can be delayed for a little bit if you want to look at the patient. So this study shows that you can delay for a little bit your coronary angiography if you have some doubts. This is the electrocardiograph 20 minutes after arrival, and as you can see, there is some normalization. There are still T-wave abnormalities, but it definitely doesn't look like it did before. The blood gases were pH 7.24, PaO2 300, PaCO2 32, and the lactate was, basic cis was -7. So what do the guidelines say about ventilation and breathing? Patients with a brief episode of cardiac arrest may not even require intubation if they're shocked and they're fine. Airway and ventilation support could continue after return of spontaneous circulation if you wish, if you feel the patient needs that support for the heart. You need to maintain a certain level of oxygenation, as was pointed out before, and you need to look at your ventilation parameters. Ventilation parameters, or a high end-tidal CO2, a low oxygenation, is pretty much a marker of neglected care unless you're actually putting in the effort to improve that patient. What about the next stage, monitoring? So here is here are the recommendations with regards to monitoring. You can see that there are specific recommendations for invasive BP monitoring, performance of repeated echocardiographies, specific targets, and specific treatments as well, which I'm not going to go into in great detail, again, because we are short in time. However, having said this, I'm going to go back to our case and ask you a question. Upon arrival, the vital signs of the patients are a blood pressure of 80/40, heart rate of 150, her rectal temperature is 35.5. Please mark the correct questions, and please do this in the chat, as we will not have a poll. There is no need to increase blood pressure. That could be one answer. The low blood pressure combined with a tachycardia suggests severe fluid leak. Just give her a bolus of 30 milligrams per kilo of fluids. Wait 3 to 4 hours to see the trend in lactate levels and urine output. So treatment is indicated if lactate doesn't decrease and urine output meets a specific target, or initiate treatment with noradrenaline and assess the needs for fluids. Please send your response now to our chat. So now that we are in the chat, we can see that Dr. Sarakoglu, could you tell us where the predominant answer is, perhaps?
And in the chat, mostly we had answer as D.
So Sharon, the answers is predominantly
D.
D, and after that is C.
Okay, great. So we have some dilemma here for some people, so let me solve that for people. The guidelines recommend maintaining a mean arterial pressure of more than 65, guided by echocardiography and by means of noradrenaline. Fluids is required in inotropes if there's a low cardiac output. So basically, monitoring is crucial here, and we would like to see people continuously monitoring the patient and responding adequately as required with fluids and inotropes. Noradrenaline, please bear in mind that there needs to be a certain, you need to take into consideration the fact that the patient may, if they're particularly, if they're ischemic, there may be an issue with afterload, increased afterload. So moving on, this is the guideline. Several studies show that hypotension is consistently associated with poor outcome. And I'm not going to cite those. You're welcome to go into the guidelines and look. But I do want to see these two papers here. This is a porcine model of cardiac arrest targeting a mean arterial pressure of 90. Here, there was no evidence. There was no evidence of change in ischemic markers. So just, shooting for those higher levels is not necessarily much better. And the next slide is also relevant to this. These are two studies looking at 112 patients and 120 patients, comparing different levels, and again showing that a certain level suffices. A mean arterial pressure of 65 probably suffices for most patients. Please take into consideration questions that might be hypertensive as well. So moving on, and then these patients might need slightly higher levels. The next topic is seizures. So the guidelines recommend using EEG as a diagnostic tool for seizures. Seizures are reported in 20 to 30% of cardiac arrest patients, which is actually higher than they were than the description in the previous guidelines, where it was approximately 15%. So we may be underestimating them. Here are some recommendations for treatment, which I'm now going to ask you about. EEG shows activity consistent with seizures. You've performed an EEG, you diagnose seizures. By the time the neurologist arrives, the patient has generalized myoclonus. What is the best treatment? Okay, so this is myoclonus, which is pretty common after CPR and is often accompanied by poor prognosis, but nonetheless, it needs to be treated. So what is the best treatment? Please vote. Again, going into the chat, and our moderators will be giving you 30 seconds in order to respond, and will be telling us what the predominant response is. Thank you.
And we have predominantly answers C. Mostly C.
Great. Thank you very much. So excellent. This is great. I have to agree with most people. Pentothal and propofol are not first-line drugs for seizures anymore, although many of the anesthesiologists, and me included, feel quite comfortable with these drugs. Midazolam is a sedative, but it's not short-acting, so it will preclude our ability to perform a proper neurological examination, which is really important. I'm going to mention prognostication. Vecuronium will induce peripheral muscle relaxation. Please do not confuse muscle relaxation. And I'm saying this less to anesthesiologists and more to the internists that may be listening to this, because the fact that the patient is flaccid doesn't mean that they are not awake. And valproate and levetiracetam are the drugs of choice. Moving on to our next aspect of care is temperature control. And I'm going to mention a couple of things here in relation to this topic. So the guidelines actually say to maintain a constant target temperature between 32 and 36 degrees for those patients in whom temperature control is used. And this is a strong recommendation based on a significant amount of literature. And as you know, there has been some controversy regarding the issue of how low to go. I'd like to mention, to say a few words about this, and I think that we may have time to discuss this specific topic later on, because I know that this is an interesting topic to mention. But basically, the guidelines do say that it's possible to also keep the patient lower than 36. Our center is actually keeping the patients lower than 36 rather than going lower than that, although we were keeping the patients lower than that before the TTM2 trial. So the important point with regards to the guidelines is not only this issue, but also the question of whether who to cool. And the guidelines currently recommend to cool not only patients, this is the hypothermia versus normothermia study, which we can discuss later again, but also patients that probably need a certain amount of cooling if they are not necessarily in VTVF, and that's an important point to bring across as well. So here is a network meta-analysis, which I purposely bring because I'd like to raise some discussion here. And here a comparison was performed between normothermia, mild, moderate, and deep hypothermia, showing that while survival was similar amongst the three, deep hypothermia had increased arrhythmias, while the mild hypothermia had less arrhythmias. And this is just the one point I want to bring across in relation to this. So anything probably a reasonable amount of non-hypothermia would be reasonable. Going on to the next issue is in general intensive care management. The guidelines say use short-acting sedatives like I mentioned before, like we would do for most ICU patients. Try to avoid neuromuscular blockers. Please take into consideration that the deeper you cool your patients, the more likely you are to require a neuromuscular blockade unless to prevent shivering, unless you're giving some pretty strong anti-shivering medications which may have sedative effects. DVT prophylaxis, stress ulcer prophylaxis, keep glucose and enteral feeding. And so this is just general ICU management. And my next question, I believe, comes here. So which of the following statements is incorrect with regards to administration of anticoagulants after return of spontaneous circulation? The only indication for full anticoagulation is proof of clinically meaningful pulmonary PE. Anticoagulants are contraindicated for 48 hours at least. Anticoagulants should be administered for DVT prophylaxis as after ROSC, just as any other patients. And one contraindication to anticoagulation may be development of thrombocytopenia secondary to the post-resuscitation syndrome. Again, my question is, which is incorrect? Please respond.
Generally, mostly the answer's B, I think.
People have got it right, and I'm proud of you folks. Patient after return of spontaneous circulation should receive good routine ICU care, including it all. And patient counts should be followed because they may decrease for several reasons, amongst not in the least because of the post-resuscitation syndrome. But if there's no evidence of intracranial hemorrhage, definitely give. The next day, you try to wake your patient up. They don't wake up. And the next day after, again, your patient does not wake up. So we're here at prognostication right here. The recommendation is to wait at least 72 hours from return of spontaneous circulation. Use a multimodal approach. Again, Professor Bodiger has mentioned this before. I'm not going to go into it, the details again. And my question is now, the patient is not receiving anything. In fact, they've not received at any point. Please tell me what you're going to do at this stage. 4 hours after arrival, your patient is completely flat. What is the correct answer?
I'm checking now the answers, and mostly we have answers B.
Excellent. So we have a great audience here. Some hypothermia is neuroprotective at this time. Although the patient has spontaneous, we know that spontaneous hypothermia is probably associated with poor outcomes. Still, the patient may be flat because they're convulsing. A toxic screen may, I don't know if you know, may miss a certain amount of drugs. It really depends what kit you're using in the hospital. Blood cultures are not likely to change management. And peak neuron-specific enolase levels are usually not seen this early, so looking at the levels at this point is not very informative, and the guidelines say to repeat them. So looking on this slide, which we've mentioned before, please note, people, that we need at least two, I'm repeating, two of these, and at least two of these criteria. Please do not withdraw care too early for these patients. Be patient with the patients. Discordant signs may indicate a better outcome, and this is really important. Here I've sort of listed the findings that may be misleading in the various components of the examination that we should be using. So basically, there's been, since 2015, I think the greatest amount of publications have been on prognostication, and definitely the way to go, because we think this is an important aspect of care. I'd like to just point out the last slide, or almost last slide, showing that cardiac arrest mortality in one of the earlier studies happened because what is called of neurological injury. In other words, assessment was performed and care was withdrawn based on neurological prognostication. But this only happened from day 3. Please not at this stage, at an early stage. Finally, please perform a neurological, a functional assessment of the patient before hospital discharge, because rehabilitation can do miracles for your patients. It's worth the effort. These patients are working to make this effort. And if the patient is not for rehabilitation, it's important to consider those patients for organ donation. That is all I have to say on the guidelines today, and thank you very much for your cooperation.
So we'll have another poll, and I'm going to ask you guys to participate. And you can use the button as I mentioned before, and I will read the poll. In your daily practice, do the emergency medical services bypass the Department of Emergency Medicine and bring the patient directly to an ICU? Answer yes or no by clicking A or B. And send that by the blue button, and we will close the poll in 5 minutes, please. And Aichin will share the results towards the end of the presentation. Is there any questions from the audience? We can actually take that, and there's now time for a bit of discussion as well.
Yes, dear Arash, we have many questions. I'm afraid we cannot share all of these questions, but some of questions I would like to direct you. And dear Sharon, first of all, first question is coming for you. And is the sodium valproate and levetiracetam first-line treatment only for post-cardiac arrest seizures and for all kind of seizures?
So again, our topic today is cardiac arrest. I'm not a neurologist. My recommendation relates to cardiac arrest, and the guidelines specifically state the drugs that I have mentioned, sodium valproate, okay, and is preferred over many other drugs. Again, levetiracetam as well. Please take into consideration the fact that if the patient continues to seize, then you may need to escalate, and it's very important to have a neurologist involved in this stage, because adding up, there's very little data on what's the second and third and fourth stage drug.
Thank you very much, Sharon, for your nice explanation. And another questions for dear Bernd. And under targeted temperature management with lower temperature targeted, what would be the preferred carbon dioxide measurement for arterial blood gas analysis, alpha stat or pH stat?
A good question. Thank you very much. We do not know. We just do not know. As we didn't know that for cardiac surgical patients, we do not know it for cardiac arrest patients. So you may use both. Maybe we just do not know it because this is not a question which is most important. So you can do both. We are choosing just normothermia for our blood gas analysis in hypothermic patients.
Okay.
So Bernd, you do not adjust for the temperature? Am I understanding correct?
We do not adjust, but you can also adjust. You can do both, as said.
Yes. Okay. Yeah. And what do you think about this question, Arash?
I mean, we actually adjust. So, but I think a lot of it is based on tradition, and I think obviously coming from Scandinavia, I may also differ in opinion in terms of hypothermia and normothermia, because being one of the centers driving the TTM2 and also the previous hypothermia trials, I may kind of disagree with Bernd on the indications, because our opinion is actually we've been going for normothermia many years in most Scandinavian sites, and that's obviously we may have another criteria for patient selection, because our patients are obviously receiving at a higher rate. We have a higher success rate in terms of out of hospital resuscitation, but I still believe that the main cause of deteriorating factor is hyperthermia and fever. And our experiences has been also not only in clinical trials, but also in reality, that hypothermia causes a lot of arrhythmia and a lot of problems for us, also in terms of coagulopathy and bleeding and other adverse events. So we go for normothermia, and which basically normothermia is 36.5 to 37.5 in reality.
You do not need to adjust temperature for your blood gas analysis if you are using normothermia. That's probably correct. but your cardiac arrest patients are probably different than mine. We do not have 60, 70, or 80% lay resuscitation rates. In the TTM trial, in the TTM1 trial, TTM didn't report this because it was probably a matter of criticism. In the TTM1 trial, the downtime was 1 minute. So and we know from Christian Eriksen, who collapsed in the soccer stadium, that if you have a downtime of only a few seconds or 1 minute, because then you get resuscitation by lay people or by some others, then you do not need to be cooled down. That is number one statement. Number two statement is we know that hypothermia is totally effective. We all know these young children going under ice in winter. They can be resuscitated after 45 minutes if they are lucky. But hypothermia needs to start very fast. And in the TTM trials, hypothermia was achieved 7, 8, 9 hours after the cardiac arrest. And if this coincidences with a 1 minute of downtime, I can easily imagine that hypothermia was not working. There is not one single animal study where hypothermia was applied after 1 minute of ischemia and following 8 hours following a cardiac arrest and being shown any effective signal. So please use hypothermia if your patients are not similar to the patients of the TTM trial. There is not so much a danger. If there is an effect on coagulopathy, this is probably positive because they all have high levels of procoagulant activity. That is my number one statement. And my number two statement is that all studies, except the TTM2, showed that there is no increased risk with hypothermia. Besides that you have to look a little bit more to the potassium levels when you cool the patients down. And it is not true that they have high levels of arrhythmias when they are cooled. In most of the studies that we have seen before, there was no significant difference. And if they have some arrhythmias, that may not be harmful and may not be associated with any worse outcome. We also know from the Hyperion trial that asystolic patients significantly profit from hypothermia. Therefore, in doubt, please use temperature management. My statement.
Okay, thank you. And Sharon, may I get your opinion about this question?
Well, far be it from me to argue between these two giants, but I have to say we used to cool the patients down to 33.5 to 34.5. Following the TTM2 trial, we now cool the patients to below 36. Again, unless the patient is spontaneously hypothermic, which is important. I think I'd like to highlight an important point that I think the TTM trial shows that has not been discussed. It basically shows that when excellent resuscitation care is given throughout the whole process, starting from the very moment from the very beginning, that target temperature management may not have as strong an effect as it has under other conditions. And I think that this is a very strong point to highlight. So if you know your system, and ours is not as good as the TTM2 trial, then you may want to change practice. So again, I'd like to wrap up. I'd just like to say one word about the blood gases. We do not adapt. We do not adjust for the temperature. We leave them in room temperature. So people, you have pretty much a lot of open opportunities to do some more research here.
Now we have the poll results. I think that, Ayten, if you can take us through that, please.
Yes, and we have 39% yes and 61% no. And what's your opinion, comments on these results, Sharon?
This comment to me is a good sign of why the TTM trial succeeded in Scandinavia and may not be generalized to other places, because if you do not bypass the ED and the patient spends an extended amount of time in the ED and it takes hours and hours to induce, you need to think again what exactly are you doing for your patient. There may be some things more important for the patient than cooling them, such as bringing them to a place where they are highly monitored and treated properly. So that's all I have to say about this.
And may I ask you, Sharon, what's the situation in your hospital?
Excuse me?
What's your answers for this question according to your hospital?
So unfortunately, our ED is usually chock full, and there are there are beds in the cardiac ICU. So those patients with VTVF are bypass the ED and brought directly to the ICU, and the others are kind of lay around in the ED until we find a bed for them, which is usually in the general ICU. So, this to me was a very interesting question, because we actually split them to two groups, specifically in my hospital, upon arrival. And that's interesting.
Yeah. What about your clinical practice, dear Bernd, and in your hospital? What's your organization?
In my hospital, cardiac arrest patients, in most of the cases, go directly to the PCI lab. And
yeah.
they are cooled in parallel. When we receive the patients, we are starting cooling when they enter the hospital, and they go in parallel to the PCI lab. And if no PCI is indicated, they go to the cardiac ICU in most of the cases.
And has this changed during COVID situation in your hospital, or for your hospitals?
Not in my hospital. So we have not changed the clinical practice. Besides that, we are using protection equipment and all this.
What about your hospital, Sharon, or for your country?
It depends on the hospital. Not all hospitals do the same. Some hospitals are actually putting the patients first in isolation, checking, and then moving them on, because they don't want to endanger cardiology patients or whatever. In my hospital, no, it hasn't changed, but other places have.
Arash, what about your hospital?
I mean, we've actually been quite privileged that we haven't really experienced COVID in the same extent, but no, I mean, we do pretty much the same thing as Bernd. I mean, they come obviously through we have a triage system out of hospital, so that we have the patients sent to main university hospitals with cardiology and in basic cardiology settings, and then we obviously go for normothermia, and this is also a question of distances. I mean, you look at distances, and the hospital, that all matters, because being a small country with centralization, and we have AEDs everywhere basically available, and children are also trained. So it is obviously true that the environment and also the setting has a massive impact, but we haven't actually restricted our treatments in terms of COVID. Bernd had a comment, and then we have the take-home messages for your item.
I just want to again point out that I agree that if you have the same patients as in the TTM2 trial, and then you should probably not need to cool them down to 34, 36 or so. But we also need to mention that it is not acceptable to leave them just without any attempt on temperature management. Because also, and here we can probably agree, Arash, because also in the normothermia group of the TTM trial, half of the patients needed to be cooled by an invasive cooling device so that they did not experience fever. So we need to pay attention that we do not bring the message to the people that we should not do any temperature management anymore. Most of patients, even in the normothermia group of the TTM trial, needed temperature active, invasive temperature management.
No, I fully agree. And as I said, what's really dangerous is the hypothermia. So we definitely basically manage the temperature regulation, no matter if it's independent, if it's children or adults. But, you know, we go for a target of 36.5 or something like that. So I fully agree.
According to new guideline, and we can teach the kids CPR and implement technologies to alert first responders. And multimodal neuroprognostication strategy is recommended by the guideline. And main target temperature between 32 and 36 Celsius for at least 24 hours should be provided regardless of rhythm and location. And we should avoid fever, and we should consider eCPR as a rescue therapy for selected patients. And stepwise approach for airway management also should be useful, and entitled carbon dioxide trends for predicting return of spontaneous circulation might be more appropriate, I think. Thank you very much.
Well, I want to thank all our speakers and the attendants and the members for joining this webinar. You have gained knowledge, and I actually found it very, very interesting. And it's nice to have a bit of a pro and con discussion anyway. So you can see our disagreements and agreements as well. I also like to remind our colleagues to complete the assessment and evaluation by 21st of September in order to earn your 1-point CME for this activity. And also, our next webinar is on the 5th of October and is on patient blood management, sponsored by Massimo. Our final webinar of the year will be on November 16 on how COVID-19 pandemic has changed anesthesiology clinical practice, lessons learned, and this is sponsored by MSD. Do not forget to visit your ESAIC Academy. The webcast of this webinar will be available on there, on the platform within 24 hours. I want to thank you all for attending and wishing you all a good evening, and stay safe. And thank you very much. It was a pleasure.
Thank you. Bye-bye.
Thank you very much.
Stay safe.
Bye. Thank you.